Welcome back to the Complicated Kids podcast. I am delighted today to be joined by Dawn Moore. Dawn, thank you for being here.
Thank you for having me.
Before you introduce yourself to the peoples, actually, I'm going to do the spoiler alert right off the top, which is for everybody listening, kids should not be breathing through their mouths. There, I said it. Okay.
Yep, you said it.
But we are going to take the next few minutes at least to say why that is. But before we do, please introduce yourself and what it is that you do.
All right. Thank you so much. My name is Dr. Dawn Moore. I am a speech language pathologist and certified orofacial myologist in Burlington, North Carolina. I've been practicing in the field of speech pathology for 25 years, which is hard to believe.
Because you're only 17 years old.
Right? I haven't aged a day since I left grad school. Like, how did this happen? Yeah. I've got two daughters that are, my youngest headed off to college in less than 2 weeks. So we're going to be empty nesters here real soon. And the oldest is going to finish her she's going to start her senior year in college. So, so yeah, obviously it's been 25 years since it's all started. And one of the things that, as you said, is the biggest thing is breathing through the mouth is one of the most detrimental things that we can do for our health, not just for kids, but for anybody. And unfortunately, it's really gone unchecked. Like, medical professionals don't talk about it. Trying to get ENTs to do anything about it has been just really, really, really hard. And it is multifactorial. So it's not just one thing that causes people to become, mouth breathers. So it's just something that people need to be aware of, especially parents, because you can get kids breathing through the nose, day one, get that tongue resting up, get those lips closed. We could really grow. And I joke, and I said this yesterday to a parent, like, I don't want you to think that I think kids are plants, but we can grow healthy children. So if we can get these things going, then we can do that. And, the sad part about it all is that Brazil has a frenulum inspection law on the books and has had it on the books since 2015, that every newborn born in that country, ties are looked at and released immediately. So,
wow.
So, everybody's like, US is so forward and progressive. Not really.
Okay. There's so much I want to unpack here.
Not really.
There's so much. Okay. First of all, you said it's multifactorial. I think this is why people stay away from it, because it feels very big and very messy. And it is.
It is.
And I'm a novice sort of in this part of our field, and I'm not planning on specializing at all. I know enough to be dangerous.
Understand.
And I know enough to refer, and I have some good referral partners. Okay, but let's talk about, let's just do a dump, because I think people are going to be amazed by this, of all of the things that can be affected. And you said breathing through our mouths is something about, like, what did you say exactly? It's like among the worst. It's
just so detrimental to our health.
Why? What does it affect?
It was really interesting because I went to a conference for the IAOM, which is International Association of Orofacial Myology. Went to one of the conventions, and there was a doctor there, Dr. Ramirez, and a dentist, and he put a baby up on the screen. Not a big deal. Everybody does that, right? And people just seem talking, chattering, how it is in conferences and stuff. And he was like, and he pointed at the screen. He said, "That baby's dying." And that was it. Everybody stopped talking. And we're all looking at the screen like, the baby doesn't look like the baby's dying. And he said, and I think the baby was sleeping, but the baby had the mouth open. And we're like, okay. And he's like, not today. He's like, that baby's dying. Like, that baby's sick. There's something wrong, and if this course doesn't change, this will invite disease. This will invite, oxygenation levels that are too low for the organs, including the brain, suffocation, all of it. And it was eye-opening to just hear that and know that that's true, and we don't pay enough attention to it. And it was one of those things where it's like, oh my gosh, like how have we gotten this far without really talking about the elephant in the room for a lot of kids and adults?
Yeah. Before people freak out,
children end up being mouth breathing adults.
Right. Okay. But before we freak out, first of all, the mouth breathing will cause, and I definitely want to get into a list.
Yeah.
It will cause chronic low levels of oxygenation.
Yes.
Of what?
Yes.
Oxygenation.
So he talked about
Yeah.
with breathing, if we don't breathe, and even just breathing in and of itself, like, because we do that clavicular breathing, if we don't use the diaphragm to expand the lungs the way they're supposed to, then we don't get the most oxygenous rich blood that comes out of the lungs, and he said mouth breathing is shallow breathing. It's not deep breathing. You're not expanding the lungs. You're not doing the breathing you're supposed to do. Think of yoga kind of breathing, kind of thing that you're supposed, belly rise, belly fall,
So
all the way through the nose.
Lack of oxygen to the body.
Yes.
Talk about nose breathing and it's special and why it's special.
Oh, nose breathing is amazing. And we don't give enough credit to the tongue. We definitely don't get enough credit, but the nose, we don't either. The nose is incredible. When the air comes in, it's filtered, that's what the cilia is there for, which we all know. It is warmed. And then there is a chemical process that happens in the nose when we breathe in. And so all of these things happen to this air that go into the nose. When you don't do that, no filtration, no warming of the air, straight into the mouth, down into the throat, down into the lungs. So we're missing a big part of that process when we breathe through the mouth.
Okay, let's talk about sleep. How does breathing affect
sleep? Yes. So sleep is, it's one of those things that, again, we just haven't paid enough attention to. And unfortunately, we treat so many symptoms of sleep disorders, ADHD, anxiety, all mental health disorders, things that are rooted in a lot of, and pretty much proven to sleep. Now they're linking dementia to poor sleep and breathing, because that's where the brain is dying, and it makes a whole lot of sense, logically. And so you think about sleep, and tongue needs to be on the roof of the mouth. If your tongue isn't on the roof of the mouth, it's going to fall back into your airway. Now we've got sleep apnea, or a version of sleep apnea, some types of thing where you're going to have, decreased oxygenation at night. So breathing through the mouth is so detrimental to overall health in terms of, it's just not going to let us sleep well. We're not breathing well. We're not sleeping well. Snoring, noisy breathing. And it's not, those kids are sneaky. Some kids are sneaky. My daughter was, which is how I got into this rabbit hole, because a lot of kids don't have snoring. They might not have an open mouth, but they still might have poor quality sleep. Okay. Quality and quantity are two different things.
Tell us about your daughter then. See, she sounds like a perfect case.
So my daughter, I diagnosed her with a tongue thrust when she was 18 months old.
And what is that?
She did sucking fingers, tongue thrust with the tongue pushed forward on the teeth all the time. And at that point, I thought tongue thrust was related to swallowing, because that's what we talk about in our field, that tongue thrust is related to swallowing and the tongue goes forward during a swallow. That's not where the damage is done. The damage is done with resting posture. Resting posture is that the tongue has to rest on the roof of the mouth, off the teeth, and maintains the upper dental arch. She didn't have that. Why didn't she have that? Because she was a finger sucker. Why was she a finger sucker? Because she had an airway problem that I didn't know. I didn't know about it. A tongue thrust is kind of a misnomer, and a lot of people think that that's the real issue. That's just a symptom. It's the body's way of pushing the tongue out of the airway at night. Yep. That is literally what a tongue thrust is. Yep. And for her, 10 millimeter overjet. That's what it caused. Her upper jaw was so far out of her head that her lower jaw fit like well up inside it. I mean, it was bad. It was really bad.
Mm-hmm. Okay. So we've got massive overjet, which most people will refer to as an overbite. So that's where teeth are sticking out.
Which is not the same thing.
Not the same thing.
But so overjet.
Right.
Overjet is this version where they stick out. Overbite is the horizontal, the vertical dimension where it goes straight over, and you can't see the lower teeth. That's an overbite. Yeah. So dental terms were real fun at the beginning to learn all these things and to like commit them all to memory, and so that you actually know that you're saying the right thing when you talk to dental professionals.
Which is like fun. A whole other thing, because again, so part of why this is so messy. It is. And there's a fair number of, professionals that listen to this podcast as well. And so people will be like, oh, it seems so scary. It seems so much. And it is like, it's a lot. Yes. You've got to interface. And also, so we'll get into treatment in a second, but like, it's not a question of the nice speech lady shows up at your house once a week and does some fun games with you. You got a contract with dentistry, sometimes orthodonture, sometimes sleep, sometimes ENT, if you can find somebody who believes that and has done the research, then also speech, so it is very much a team approach. And if if you're a person, and again, I'm talking from the clinician side here, if you're a person who just wants to help people, it feels like a lot of legwork to go and build a network of nodes of different people that you may be intimidated by, right? Like,
oh yeah, 100%.
And so that you can help the people's children and adults, by the way, right?
Yes.
As you keep saying,
Right.
in the way that you now know, because one thing's for sure, once you see this, you can never unsee it.
No, you can't. You can't. I was told to stop diagnosing people when we were out with my, my family. They're like, stop diagnosing the waitress. And so I did, I literally shut up about it, and now they do it.
Right. My kids do the same thing. Okay. So walk us through, let's go back to your daughter. So she had an airway issue. She had a massive overjet. She was sucking her fingers to get her tongue out of the way of her airway when she was lying down, which is another whole thing, right? Sitting up versus lying down. Sleep disturbance, brain disturbance, ADHD, learning disorders, whatever. Walk us through what happened next with your daughter.
Yeah. So I stopped the sucking habit pretty quickly at about 18 months, but then I was still measuring kind of like, is the overjet continuing, and it was, it just kept getting bigger, 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 bigger. So I went to Chapel Hill Dental School in North Carolina, thinking like maybe they know what's going on, because I knew it was a tongue thrust, but I didn't really know at that point about the airway stuff. I had no clue about that at that point. And they were like, so she sucks her fingers. I was like, she used to, she hasn't done that for 3 years, and so I happened to look away at my husband and turn back around, and the dentist, the student dentist, was looking at her thumbs and looking at her fingers. And I'm like, why am I coming here and going to lie to you?
Right.
Because he had no explanation for why her teeth were still moving.
Okay. Yeah.
And that was was it. That was very interesting to me. And so I was like, okay, so moving forward, I'm trying to get some dentists to help her. Everybody's like, we'll just break her jaw, when she's older, and we'll do this and we'll do that. And of course, I was told the biggest thing was that form drives the function. That was what I was told over and over again. We got to fix the form, and then the function will fix itself. And now I know that is not true. The function will destroy the form very quickly.
Stop here.
Very quickly.
And this is where I want you to clarify a little bit, because going back to your comment about Brazil is doing frenectomies on anybody, let's talk about structure, form, and function.
Right.
Give us, because I have a particular point of view. I'm curious to hear yours about the interplay, because that's a bi-directional process.
It is. It is. And to think that one is more important than the other is where we've messed up. And that's where the field of dentistry firmly lies and continues to lie to a certain extent. Not understanding that the form and the function change over time as we grow. It's like when you're born, you're not talking because you don't have that function yet, because you don't have the form, so it's these things that are just, it's bi-directional, and it changes as we age, and so what we see with infants who are getting tongue tie releases, which is great, sometimes they might be a little conservative because they're just trying to get the baby to nurse, which makes 100% sense. But when you get to the point where they're in solid foods, then it looks like, wait a minute, maybe that release wasn't as good as it needed to be, because now the function has changed. Okay. And the function is different. And so it's a very fine line between understanding that these have to work together. And a lot of professionals, unfortunately, don't. They don't understand that we've got to fix both. And that it changes over time. That's a big thing.
Yeah. And I appreciate that. But there's nuance there too, right? Because aren't we all have different form. I've got one eye that like leans down a little more than the other. So where's that clinical line? And I think this is where this specialty in particular, I think this is true of speech pathology in general, but like it's a mileage sport. Like you don't know what you don't know. You got to learn it. You're going to learn it over time. You cannot learn it all at once. But like walk us through, like, what's your point of view on that? Like we all have different structure. That's how we're made.
Right. So the biggest push is that, you got to have that functional impact. And so you look at Brazil's frenulum inspection law. At that point, if they're investigating this it's almost like our newborn hearing screenings.
Yep.
As soon as they do it, like everything's good, you go on, you're fine. There, if they identify a tie based on their protocol, they release it. And I don't know if there's a functional assessment. I don't know enough about it to say, what are they doing in terms of function? But somebody had said recently, if children were born with fingers that were fused, they would have no problem with releasing those. That wouldn't even be a question. But the minute you're born with a tongue tie, they're like, you need to show that there's a deficit before we touch it. And that has led to me having a 7-year-old in my office with one of the worst anterior ties I've ever seen, whose twin brother was released at birth because he had feeding problems, but my little boy did not. And so here he was at 7, a big old mess because it wasn't done.
And what were his symptoms? So the 7-year-old did not
Oh
have trouble
what were
feeding,
his symptoms?
but he still had an R.
Yeah, well, he breastfed like a champ.
Okay.
And that's the thing. Like some people can make it, but yeah, R issues, speech issues, feeding issues, how his face was growing, his sleep was horrible, his attention was bad. I mean, he had all of it. He had just all of it, and it was really tough for him.
I want to draw this line directly again so that people understand there is a direct correlation. We won't say cause, but direct correlation between airway and behavior. And
yes.
Because of the sleep component, right?
Yes.
So breathing begets sleep, begets good behavior.
Yes.
Airway problems beget sleep problems, beget behavior problems. We can throw diet into the mix as well.
Of course.
Right. And so,
diet, vitamins, all of that.
Diet, vitamins, minerals, I'm finding out.
Yes, definitely. Iron's the big one. Yep.
Okay. And probably, I suspect, that airway is contributing to how those things are metabolized in the body. Wouldn't surprise me to know that there's a relationship between the gut and the airway.
Oh, definitely.
Right. So, okay. But the point is back to like multifactorial, very, very messy. Where do you even start? Like if parents are listening to this and they're like, oh shit,
right.
What do you recommend people do?
So my recommendation to parents is I always tell them to start with a functional baseline assessment. So looking for a certified orofacial myologist, a myofunctional therapist to do an evaluation and know that myofunctional therapy is for ages 4 and up. Yep. 4 might be even a little young, just depends. And I've worked with 4-year-olds that are very mature and have had good results with it, but not everybody can do it. I've worked with 7-year-olds that couldn't do myofunctional therapy. Everybody's different, just depending on their attention and their maturity and stuff. But you start with that baseline evaluation with a myofunctional therapist. The thing that is happening now is so many dentists are getting into this, which is great, but they're just like, oh, you have a tongue tie. You want me to go ahead and release it? No. The answer to that is always no. Absolutely, positively no.
So glad you're bringing this up because this is where we go back to our form and our function, which is we've got to deal with function and get some things. It's like you would not do surgery. You might people would do surgery. So never mind. I'm not even going to go there.
You wouldn't run a marathon.
There you go.
Without training.
There you go. Thank you.
And myo to me is a marathon. There's a lot that's coming your way that's going to have to be addressed. And you don't want to just jump right into it, especially with a tongue tie release, because that is not the biggest issue. For most people, airway is the biggest issue. And if you have a mouth that has a form that is too small, that tongue can't fit on the roof of your mouth, meaning that if you get a tongue tie released and you're an adult who isn't growing anymore and you don't have a garage big enough for that car, guess where that car's going? Right down your throat when you sleep. And that's what we see with a lot of adult patients that rush into these procedures because they don't know. Nobody has told them. So trying to get them to understand there is a process that should be followed. And for me as the therapist, I'm the one that guides them through that process. We spend a lot of time, running up the hill and shouting at the wind. But in the end, my goal is to guide them through the process of the people they need to see to get that kid back on the path that they have veered off on. And that is the biggest thing. If you're going to veer off on a developmental path, the only way to get back to it is make some turns. And you can't stay on that developmental path that you're on and expect good growth. And we're not seeing it. And that's what's happening to so many of our kids. And so many of my staff are like, oh, can you go show us a normal tongue frenulum? Can you show us a normally developing child? No.
Really?
No, I don't have.
This is really interesting. Okay. So And there's a great book by James Nestor, Breath,
Yes.
which is
Yes.
like digestible for people.
Yes, it's awesome.
Yeah. So faces are getting smaller,
Oh,
jaws are
God.
getting smaller
Yep.
because diet is softer. That's like the evolutionary
It is.
explanation for why this is happening.
Yep. We
But
don't chew enough.
We don't chew enough, but it's really hard. And again, people should read the book if they're interested, but it's very hard. Have you found challenges in explaining this to people and getting buy-in? Or
Oh, definitely. Yeah. Definitely. Yeah. Especially when I first started, it was, you have people that are, you just think like they're really on board and everything's going to be great. And then like crickets, like you never hear from them again, and I just, it sucks. And I feel bad for the kid, or the adult, if it was them. But you can lead a horse to water, that's,
I think the other
all you can
thing,
do.
it's such a journey. Like this is, and I
It is.
feel like
It's
for
not
whatever
easy.
reason, right? Like in terms of like, okay, my child has a feeding delay or a speech delay or whatever. It's like, I take them to the speech therapist and they go for some amount of time. And even if it takes 2 years,
Right.
somehow people can wrap their brains around that. It's newer. It's not super new.
Right.
But it's different appointments. We didn't even talk about body work and posture.
Yep.
All of which is impacted because of the fascia around our bodies. And when you've got, I like to think of it as a body sock.
I call it the Spider-Man suit.
Yeah, the Spider-Man suit. And when there's a wrinkle in the Spider-Man suit and that wrinkle is under your tongue, now you've got all this compensatory stuff happening. You've got headaches. Oh my God. I'm going to tell you a story. My husband I'll tell you 2 parts of this story. The day he went to have his lip tie released, he had a severe tongue tie, like heart-shaped tongue, ridiculous. Had a lip tie released at the same time, which was a mistake. Don't ever do 2 ties at the same time. He had 6 done at the same time.
Oh, that's a lot.
Yeah, no, he was traumatized. But he had a migraine when he went to that appointment. And as soon as she lasered the upper lip tie, it disappeared.
It's gone. It's amazing.
Evaporated.
Mm-hmm.
And so the migraines, headaches, shoulder, posture, jaw clenching, grinding, teeth that are being worn down from the grinding, like this, all of these are symptoms of what we're talking about here. So that's like a class 2 list of symptoms. Yeah. Okay. Sorry. I keep diverging from your daughter's story, which I would love to go back to.
It's such a big area to talk about, and there's so much that goes into it. And that's why I like to think of myself as the one that can help these patients navigate that. That's what I take on as that role, and it's disheartening in our field when a lot of people are like, oh, it's just this money grab. And, you're not really doing anything and you're charging all this money. Like the heart and soul that I put into my patients, like to get them on the right track and to get them growing better is just, I can't even, there's no price tag on that, because for me, it's a labor of love. I mean, it really is. Yes, I get paid for my services, but I'm not also out there like, okay, everybody needs a tongue tie release. Like that's not what we're about. We're about function.
I will say it's not cheap.
It's not cheap.
And it's not covered. Often
it's not covered. Well, you know what is funny? Ironically funny, I'm getting more and more referrals from insurance companies for patients that are going down the jaw surgery road, where they will not pay for the jaw surgery until they have the myo eval and plan and treatment in effect before the surgery is done, but they won't pay for it.
Wait, back it up. Hold on. Wait, so they won't pay for the surgery
until they have the myofunctional evaluation, and I send that to the insurance company.
So then they want the myofunctional evaluation in order to do the jaw surgery?
Yep, and they want the treatment plan in place.
But they won't
pay for the myofunctional evaluation. Oh my God. Yeah. So backwards. So backwards. But they don't want to pay for the jaw surgery again. Not that they probably would, I wouldn't imagine. But yeah, it happened so many times over and over again. It's surprising that, so the word's getting out, but not in the right way. Yeah, it's crazy.
Oh, okay, so back to your daughter.
Yes.
Took her to the dentist. They were like,
they didn't do it. They just wanted to break her jaw later. Finally found a therapist online in California. This was in 2013, about 2012. Nobody was here.
Yep.
So found her, she was a registered dental hygienist. And so worked with her and went through the therapy with my daughter, who was not the best patient. And then was like, I needed to get certified, and found the one that ended up doing my training, who actually happened to be in North Carolina, and went and did a class in 2013 and continue to try to learn as much as I can, and learning from all different kinds of people. I'm learning from dental hygienists. I learn from dentists. I learn from, dentists, from orthos, from just speech therapists, anybody who's got something interesting to talk about in terms of, because a lot of these things that we're talking about, a lot of it's not proven yet. It's clinical practice coming to the forefront of, let's figure out how we can help people now, because we can't wait for that randomized control trial.
And this is where it does get sticky, right? So if we're looking at it from both a clinician and a patient standpoint, right? Which is, okay, we're going to be out of pocket for the dollars. We're going to be seeing multiple clinicians, multiple practitioners. And I hear you on the, you're quarterbacking that, which is amazing.
Right.
And we don't really know how long it's going to take.
Yeah.
And we're going to have to course correct. Having just gone through this with my teenage daughter, who went through, she was a thumb sucker when she was little, had a very small face, as I do. I'm sure you've been analyzing my face all the time.
I actually haven't. So that's good.
That's good. You will. But she had a very narrow jaw. And once I started learning about this, I was like, oh, crud. She also is missing some permanent teeth. And so the orthodontist.
They pulled them, or they were just not there?
No, they were not existent. She did not have any teeth pulled. But here's what did happen, which is the orthodontist tried mightily to move teeth around so that she would have enough space. And unfortunately, I don't even know what they're called, right next to your front teeth, that are missing. She never did have enough space because her whole facial architecture
didn't grow right.
Too small. Right. So now, as a 15-year-old, we started her with some myofunctional work and a MSE, a maxilloskeletal expander. It's changed her whole face, but on day 5, she was like, Mom, I can breathe so much better. And here's the other thing. We are used to thinking that when you have a cold, that you're not supposed to be able to breathe through your nose.
Right.
This was life-changing for me. This happened recently, and she's 17 now, so it's been a couple of years, even maybe a year, that we've been doing it. She had a cold a couple of weeks ago. She could still breathe through her nose.
Yeah.
That's amazing. Normal.
Mm-hmm. Yep.
Right. Yep. That shouldn't be unusual.
Mm-hmm.
A lot of kids that I see are chronic mouth breathers because they're chronically congested, because, again, nutrition and picky eating and all the things, mouth breathing and small and all that, right? So everything. But we're used to thinking that, it's okay for us to breathe for just a couple of weeks through our mouths because we can't breathe through our nose because our nose is congested. That's not the case.
Right. Well, we're also used to thinking that everybody needs braces and it's a rite of passage. How do we get there?
Yes.
That's ridiculous.
About how we got there.
And it was genius on the orthodontist part to give you a retainer to wear for the rest of your life that you're never going to do. And the minute that you stop wearing that, guess what's going to happen? Oh, your teeth are moving again. And then who are you going to blame? Yourself. So, which is what we do. And then we're back into the orthodontist chair for relapse, so it's a very interesting journey that we've all taken to get to this point. And we're still learning. And that is the entire point of medicine and clinical practice. And I think that's the thing that makes me so angry about people that are like, oh, it doesn't do anything and it doesn't matter. And we don't need to move our tongues that much for speech. And, we don't need muscles, for speech. And we shouldn't worry about that. Do you hear what you're saying? Are you listening to what you're saying? You're saying we don't need muscles. We don't need much movement. We don't.
Now, this is where let's go a little inside baseball here about speech language pathology in general, which an interesting post on Instagram the other day, which is we should get rid of the pathology thing because for various reasons. Anyway, that's on my mind. But in my experience, in my opinion, the field has been so, and I think I understand where this is coming from. So I'm going to say what I'm going to say, and then I'm going to clarify, and then I'm going to ask you. The field has been so hell-bent on being taken seriously because for a long time, nobody was studying children, nobody was studying language, and there were mostly women who were doing this, right? And so as a woman-driven field, I think the impetus was very much toward like standardization, clinical, research-based, like, right? Like, get it serious, get that stuff locked down and locked in.
Right.
And so when something new comes along that destabilizes prior
Knowledge.
ideas and knowledge, what are you
Yep.
getting from this? Yeah, like it
Met
makes
with a
sense
lot
to
of
me
resistance.
that it gets met with a lot of resistance.
Yeah.
And then if you have spent your entire career like being like, this is how it is, now you feel very threatened by anything new, regardless of whether or not it's helping, which is it's so tricky.
Right. Right. It is. And, it's funny because on ASHA's portal for clinical practice for speech sound disorders, they list like, organic, non-organic, functional, non-functional. And, you've got the typical things that you see in speech sound disorders, apraxia, the, motor cortex, that kind of stuff. But then you have this subset and this main section of speech sound disorders. And I post this constantly because people need to realize functional speech sound disorders, and underneath says no known cause. And here we are, and it's 2023. We still don't know what causes children to have speech sound disorders. I know when it causes children to have speech sound disorders, but ASHA as a whole and our field as a whole do not. Muscles, function, how we grow, how the teeth line up. I mean, to me, it's so logical, but for some reason it's not to our field.
And you were in grad school in when?
1998.
Yeah,
when I graduated.
And I entered
right when the newborn hearing screening thing was coming about. So think about that too. That was not that long ago that newborn hearing screenings were not a norm.
Were not a
and
norm.
It took a long, long time to get through.
And listen, when I was in grad school, you could not say oral motor.
Oh,
you could not speak those words. And Sarah Rosenfeld Johnson, who is the founder of Talk Tools, who is a pioneer in our field, as far as I'm concerned, an unrecognized pioneer. And there's an interview with her if you want to go listen to it on the podcast. Got her name dragged through the mud for understanding the hierarchical nature.
That muscles matter.
That muscles cause speech and feeding to happen.
That muscles are important and that we've ignored them for too long. Yeah. OT and PT doesn't do that. I don't know why we do. It's a very strange thing.
Well, and this is what I'm saying in terms of the origin of the field, right?
Right.
We went so heavy on language,
right,
that we forgot that language is mediated by the physical act of speaking.
Yes. It's kind of important and goes hand in hand. And it's funny, a funny story. When I first started in early intervention, when I started our private practice here, I go into every kid that I would work with, and I was starting on sounds. Just consonant vowel reduplication of syllables and stuff, created a whole program for it based on cycles, and I brought it down to that level. And I was getting such pushback from all of the early intervention coordinators for our early intervention program because I was working on speech and I should only be working on language.
I mean,
and believe it or not, that is not, I wasn't forbidden to work on it, but in some states they are. I think it's New York. They are not allowed to work on speech sounds under 3.
Wow.
Yeah.
I mean,
so
that's
you're not allowed to have a goal for it. You're not allowed to work on it. You work on it indirectly, but you have to work on the language. And, I'm just like, speech and language are not mutually exclusive. Up until a year, okay, fine. But once we hit that year mark and we got the babbling, but even then, I mean, we're babbling before then. And I just like, there's no magic button at 3, a switch that's going to flip. That's like, okay, everything's good with sounds.
Well, and this is interesting. Okay, so we're going to bring it back to like, okay, what can parents do? Which is what we want and need people to keep looking at is, to your point about which road are we on, and do we need to make a turn, right? Because it's completely true. If we've got a toddler who at age 1 or 18 months or whatever is doing what we want them to do, but we're seeing that they don't have the motor planning, or the muscle strength or capacity or even the breathing to be able to proceed to the next level.
Yes.
We got to be laying that groundwork earlier than we expect to see the milestone.
Right.
Like,
Yeah,
that doesn't make any
and that's the
sense.
problem. And by the time it's identified, we've lost so much ground, you know, and I'm still seeing, even in our own field, I'm seeing it, which is still shocking to me, the wait and see approach. I'm seeing it constantly on social media in mom groups where SLPs are telling other SLP moms, like, I wouldn't worry yet, you know, I would just wait. And I'm always the one in there like, you have a concern, do not wait, because you can never get these years back.
I'm with you.
So get on it now. And if everything's fine, everything's fine. But if everything's not, now you know, and you can form a plan and move forward. And it still shocks me that SLPs are still telling other SLP parents to wait and see. I think they sound good right now. Like,
right. And this is, again, though, this is where in the specialty area, there's very much a focus on quality, on frequency, on prerequisites. Right. And you are not in the business of creating a shack into which we're going to put like fancy furniture.
Right.
Like,
right. Which is pretty much what we're doing with our kids now.
Which is what we're doing.
Yeah. We expect it all to come together, but we're not laying the groundwork to allow it to come together. And we're not intervening enough. Doctors are keeping us from intervening. We're keeping us from intervening early enough. And we're not looking at the right things. And that's the biggest thing that I've seen with going down into Myo, is that we're not addressing the issues that are causing these things to become a problem as they age. And that's the biggest problem that I see right now. Yeah. Okay. It's tough.
We're going to wrap up in a few seconds, but I do want to come back to, because many of the people listening to this work with or have children who are under the age of 4, sketch out a little bit, if you would, sort of how you treat those two populations differently. Let me just preface, myofunctional therapy depends on a person being able to imitate directed movement. In other words, watch what I'm doing and try to do the same thing, which obviously in a child who's younger than 4 is very challenging, if not impossible, depending on the kid. Go ahead.
Yeah. So with the younger kids, I typically refer them, because I don't do feeding. I don't treat the younger kids. I might do the evaluation, the functional assessment, and then I typically will send them off to one of my feeding, an oral motor, oral placement therapist type of thing, because that is a very different skill set. You know, you're looking in that realm of things. It starts at birth. So you're looking at, you know, it's nursing, it's lactation, it's early feeding milestones, you know, or early oral motor, all of those things. And that's a very different skill set than what most myofunctional therapists do. We can identify that there's an issue. But, you know, one of the things that's a problem in that age range is it's hard to want to get toddlers to get a tongue tie release. So if that's a road that they've got to go down, we've got to do a lot of work before we get there. We've got to do a lot of oral work and break down, you know, oral defensiveness, because we've got to get a stretching protocol in place before and after. They've got to be good with people in the mouth. It can be done as long as it's done well. And you're working with a good therapist that understands it. And it might be that you might just have to wait on it, and you do things in the interim. We have things like the Myo Munchie, where we can start working on jaw strength. You know, there's talk tools, you know, there's a lot of protocols that people have there. And so those are the things that people can implement in the younger years. And they've had really good success. At least at that point, you're moving forward. And you know you're doing something that's going to benefit that child. It's not going to fix everything because they're too young, but you're getting on the right road. We're veering back. We didn't turn, but we're veering back. We're yielding.
And you're, you know, potentially creating some nice functional and structural changes for the future, right? At least headed in the right direction.
Yes. And the biggest thing I tell my parents too, if you've got a child, you know, you've got a kid that's a year old and they've got teeth, and those teeth have no spaces in them at all, you're already on the road to development that has gone awry. And every child that walks in our door is pretty much that. You know, at that point, you already know you've got an issue. You know, so we know these things pretty early on. You got a kid that's born who's got a recessed jaw and is mouth breathing, you already know you've got an issue. So these things are identifiable pretty early on, and we just need to look at the signs. You know, pay attention and do something.
Yep. I love it. If people want to find out more about you, how do they do that? And tell us, like, who you're working with and where and how.
Okay, so so my website is thetonguedoctor.com. I got my clinical doctorate in 2018. Actually went back to school because I wanted to be able to talk to other doctors, and I hate to say have that title, but that's opened up a lot of doors that were not open to me before. It gave me some more respect in the doctor community, you know, the dental community as well. So so the Tongue Doctor website is my website. Have a lot of information on there. Just, you know, not so much, I mean, it's about our practice, but there's a lot of information, just general stuff that people can read about, learn about, you know, how to find a myofunctional therapist in your area, you know, that kind of thing, because there's a lot more now compared to what was 10 years ago.
Yeah.
But in more rural areas, it's still hard to find people. A lot of us work online. I have licenses in Georgia, Missouri, Arizona, Illinois, North Carolina. So a lot of us have, you know, multi-state licenses just so we can do online therapy. It's not the best, you know, it's not as great as it is in person, but I've had great success with it online too. So yeah, it is a possibility. And if this interstate compact ever gets up and running, we'll all like have free roam to kind of do at least all the states that are involved. And I'm one of them, so I'm excited.
Ooh, I know, and I'm in
Yeah.
DC where that
Yeah.
has not signed on, but I'm also licensed in Maryland and Virginia. So
There you go.
I think Maryland is on it. So.
Yeah, it has to be where you live.
Oh,
that is the caveat that somebody I'd read the other day. So you have to live in a state that's in the compact to go to the other states. So, but yeah, it's a lot of states that have joined though. So it's pretty interesting. Also kind of scary as well. So there's not, I'm not sure how they're going to do the oversight. So, but you know, but it's opening up some doors for people that wouldn't have treatment. And that's always a good thing.
I agree. I mean, I just think, yes, the more choice
yes,
consumers have
exactly,
choose the person they want to work with who matches their needs, the better.
Yeah, it's better for everybody.
Yeah. Don Moore, Dr. Don Moore, the tongue doctor.
Yes, ma'am.
Thank you for being here.
Yeah, thank you so much for having me. It was great talking with you. And we could spend 8 hours talking about it all.
And we will have you back. We can like niche down a little bit and like talk about something. We can take some questions. We can do all of that.
That'd be cool.
Yeah, I think that would be
that sounds great.
So
all right.
To be continued. Thank you.
Yes, ma'am. Thank you.